said, my grandbabies are just still babies, and I want to be around for them.
If you do it, get it, and follow the doctor's advice, I think you'll enjoy it.
I'm doing now what I was doing before I really got sick.
I'm Dr. Chandrasekhar. I'm a board-certified cardiologist. My interests are in heart failure. Heart failure has become a very big problem, especially these days, because more and more people survive heart attacks, survive open heart surgery, survive valve surgeries, and so they end up with worsening heart function. And it's the most common reason for people to be admitted to a hospital in the United States. So it's a very big public health problem, it's a very big community problem, it's a very big hospital problem. And actually, hospitals are now forced to prevent readmission because of penalties, because these patients frequently come back for readmission. And every admission to a hospital makes their heart function worse and their prognosis worse and their likelihood of survival less. So it's a very big problem, and that's my big interest in people with heart failure, diagnosing them early, getting them to the right care early, getting their medications titrated to the right doses. That's a big thing for me, and that's what I work on.
My name is Cynthia Wolford. I'm a board-certified heart failure nurse practitioner, and with Dr. Shaker, I run the heart failure clinic. Patients who have severe heart failure have an inability to pump the blood efficiently to their body. Many times, patients who have advanced heart failure can have an artificial heart pump, such as the HeartMate 2. The pump is actually a continuous flow pump that is implanted inside the body and actually acts as a pump for the heart that's too weakened to pump the blood on its own.
A left ventricular assist device is a continuous flow pump which helps the left ventricle get blood out. So the outlet of that pump is in the apex of the left ventricle, the tip of the left ventricle. So blood comes out of it and goes through the pump and is pumped back into the aorta so it can carry blood to the entire body. It is a fairly complex surgery, although it's compared to, say, open heart surgery, it is a smaller procedure. Patients are obviously very sick. It's a continuous flow pump. So what happens is that the pump itself works like a rotor. So you will hear a hum like you're in a motorboat. Also, because it's continuous flow, the patient will have no pulse and no blood pressure, and that sometimes is eerie. Even they present somewhere and the nurses or doctors don't know, or even a bystander. That can be scary, because if you by any chance see that person sleeping, you wonder if he's dead because he has no pulse. So those are some of the issues with it. But on the other hand, because it helps the left ventricle get the blood out, it helps the heart recover to be able to pump blood out in a weak heart, and that helps the patient get a lot better. It's something that originally was being done before somebody would get a transplant, because people who needed transplants and had very bad hearts and very weak hearts would often not be fit for that kind of surgery. So an assist device was placed to try and get them to shape where they could handle a major surgery. It started off like that, but as the technology evolved, more and more people survive with it, and so now there are patients who don't qualify for a transplant because of age or other problems, and those are all candidates for ventricular assist devices, and that's called destination therapy. People who are older, who cannot have a transplant, can still have a meaningful life and a quality of life with a ventricular assist device. My interest in this came a few years ago. I had this gentleman that I saw. I was on call. This was a middle-aged gentleman who came to the hospital with a massive heart attack. Unfortunately, his symptoms were not what he thought were heart, and therefore he delayed coming. So by the time he came to the hospital, he was so far gone, so far ill, that he was placed on a ventilator. He was very sick. He was subsequently taken to the cardiac cath lab. He was found to have very bad blockages and a very, very poor heart. So the surgeons basically felt he was inoperable. He would never make it off the table. So my sign out for that weekend, I was on call on that weekend, and so my sign out was that the family had all agreed that nothing could be done. He literally had the last rites read. He was just waiting for some family members to come so that all the tubes could be pulled. He had tubes everywhere, and so in theory that would have been an easy weekend thing for me to do. All I had to do was say he's still alive. I went there, spoke to the nurse, who said, yes, he's still alive. We're waiting for his daughters to come. They're supposed to come later today, and then we'll start pulling the tubes. And what I did was I went to the room, I called his name, and to my surprise, he opened his eyes. And I asked him to squeeze my hands, and he did. And something came over me, and I said, why are we letting a 50-something-year-old gentleman die without us even trying? And so the nurses said, well, that's what everybody feels. If nothing can be done, what else can we do? So I said, let me talk to his own doctor, and I spoke to him, and I said, there should be something we can do. Let me call Tampa and see. This man is still not even 60. He may be a candidate for a transplant. It's a far, maybe I'm outguessing myself, but let me give it a shot. So I called up the doctor in Tampa. I went and spoke to the family, and even the primary care doctor told me, he says, don't set their hopes high. They've already given up on him. Now we don't want to set their hopes high. And I went and told them, I said, we don't know if they will even take him. He's so far gone. But let's give it a shot. Ended up about 4 days later, he went there, and by this time he was not even responsive. And in my own mind, I thought, did I do the right thing? Did I cause so much of expense for this family for something that they could have had closure? He went there, and I didn't see him for a few months. A few months later, my son was graduating, and at the graduation ceremony, I saw this man in a wheelchair who basically called out my name, and I turned to him, and he said, thank you so much for saving my life. And I couldn't understand who he was, because when I saw him, he had tubes from every part of his body. So I didn't recognize the man. I was thinking, who is he? And then his wife came, and she looked vaguely familiar, and she said the same thing. She said, thank you so much for saving my husband. And I didn't notice this gentleman until a week later. I found out that it was the same man, and now I met him, and it's now 4.5 years later, and the man's still alive and well. And that's a chilling thought, because that's, after all, why I chose to be a doctor.
First time I saw him was at his son's graduation after I got out of the hospital, because I happened to just go there for one of my kids that worked for me invited me to go to the graduation, and I forced myself to go because it was indoors. And I met him for the very first time after the fact. And then he looked at me like, who are you? So I mean, well, it was a little different. At least I didn't have a mask, and I was walking instead of laying in bed with tubes. So I mean, it could be.
A lot of people with heart failure have very poor quality of life, and they don't realize it. They think it's part of their life. They think it's normal for them not to be able to do their normal activities. Sometimes they can't walk to the mailbox. Sometimes they can't go shopping without having to sit a couple of times, and they assume it's because I'm now old enough. It's a shame, because there are therapies that are available, and it's at least worth approaching instead of just giving up on hope. And that's what I feel strongly about. And I think if we want to look anywhere, you can look at Dick Cheney. If he can get a transplant in his 70s, now most other people in this country would not get a transplant in their mid-70s. But certainly, Dick Cheney went through a ventricular assist device before he had his transplant. And certainly that's a therapy available. If not a ventricular assist device, there are some intravenous therapies that we can do as an outpatient, at least to keep the patient comfortable, active. Because after all, these days, increasingly, it's not just surviving, it's what kind of life. The quality of life is what's very important, and that's what I think is paramount in our decision making. And if nothing else, nothing can be done, and if the patient does have to, that nothing can be offered and he or she does have to die, at least then we can let him die with dignity instead of having to keep going to the hospital and having multiple tubes in them before they die. There's nothing wrong with somebody dying in the comfort of their home with their loved ones around them. I feel very strongly about that, and that's what I try to bring to this practice. Basically, used to be that the most common reason for a patient to be sent or evaluated for a ventricular assist device was like that patient I described, somebody who was with one foot in the grave. Those are what are now called crash and burn patients. They are very sick, they are on multiple drips, on multiple tubes, usually on a ventilator, and their likelihood of success is very low. But nevertheless, that's the only treatment that was being done. As ventricular assist devices got better and people were surviving, it makes more sense that we don't wait until a patient is so sick. So then the next step was people who are on intravenous drips but not necessarily on a ventilator, who are still very sick but probably are able to talk and they're still in the hospital. That's the next step. But increasingly we see patients who are well before that, and those are the patients that we want to catch, where somebody can't do their normal activities, are pretty sick, although at rest they can sit and talk, but they are so sick that they may not be able to make more than 3 or 4 sentences without getting out of breath, or every time they get up and go to the bathroom they get out of breath. That's the kind of patient that we want to find before they get to that point where they are so sick that they have to be hospitalized, or they've been hospitalized a few times and they've made it home, but within a few days or few weeks they're bad enough to go back to the hospital. Those are the kind of people you want to find before they get to be that bad. You try and get them in the process. Years ago, I used to try and locate patients younger who would be transplant candidates. Even if they were doing well, I would always tell them it's better to get a foot in the door in a transplant program, so at least you're evaluated, and then we can see what else can be done. You may not need it, God willing, you may never need a transplant or a ventricular assist device, but there's no harm done in assessing you. And there are tests that can be done. You can assess their exercise capacity, how much can they do. There are things like a 6-minute walk. There are cardiopulmonary stress tests. There are some pulmonary tests that can be done to see, is it lungs that are the cause of their being out of breath, or is it the heart? There are a lot of things that can be done to assess them, and some of them we do on a routine basis. We do plethysmography. We do things that we can somehow assess the heart and see how bad is it, what can be done. Is the patient a candidate for a biventricular pacemaker, which may give him some more boost, and so forth. There's a lot of things that can be done. Most places that implant have some kind of support group even before, because before the patient goes through this, they need to be able to talk to other people and get some kind of familiarity with what happens. So most places do have it. But even after, it's very important to have some kind of support group, so people trade their own experiences, their own fears, and so on. And we are trying to create something like that in Polk County, because there are increasingly more patients in this area who currently have to go all the way to Tampa or Gainesville or Orlando, and not only from Winter Haven, but places further south of here like Sebring or Lake Wales. It's a long drive to be routinely going. So yes, we do have a support group here, so we can discuss these things and discuss some of the issues and concerns that patients and family members may have.
We have the support group on a biannual basis, and it's a time for patients who have these pumps and who have severe heart failure to come together and talk about their experiences and get support.